Okay, so today I'm here as a physiotherapist to teach you and let you know about some of the treatment and strategies for dealing with OT and what the minuscule amount of research says and how do we work around that. So, a bit about me, which Joy has already talked about. Born in Australia. Actually, my mother's Australian. I lived half of my life here. I studied pre-med science while majoring in psychology at Hunter College at CUNY in New York. And then I moved back in 2012 after being accepted into the Doctor of Physiotherapy program at the University of Melbourne. I currently work as a private practice physio at Docklands Health in Melbourne, which is in Docklands on Collins Street in the new precinct down near ANZ there. And I stumbled across OT purely by chance when a patient presented to the clinic, which was what Joy was referring to. And it was really interesting because, Joy, did you call or did you come in? No, I called. You called. And I think you wrote down OT, and the receptionist had it. And she came around, so you probably don't know this, but she came around. We have 8 physios working in the center. And so this is really important for you, which I will get into, is that when you're looking for a physio, what the questions that you need to ask. So the receptionist said, does anyone want to see a neuro patient? Well, of course, you know, as physios, we all have horror stories about our neuro placements in hospitals and how difficult they were. And that people are like, no. But I was like, yes, I will see a neuro patient. Orthostatic tremor, that sounds interesting. So one of the most important things you can do is to find a physio that has, if they don't know about neuro, and especially if you live in a place like Warragul where you're not going to have the specialist physios, is to find someone that at least has clinical curiosity. So that's important. Anyway, next slide. So what we're going to go over today is what the research says about physiotherapy and OT, how to find a physio and the questions that you should be asking them so you don't waste your time, what physiotherapy treatment looks like, and then a bit of a case study there, and then just talking about what I referred to before as the allied health support to make sure that you get all your team on board. So, and then we'll have a little question period at the end, okay? So the evidence. Physiotherapists are evidence-based practitioners, so we like to know what the evidence, what the research says before we do something. We don't want to waste your time, we don't want to waste your money, but sometimes we have to go with clinical experience, which is a little bit different because the studies haven't been done. So what does it say? Surprise, surprise, there's very little research on OT and physiotherapy. The most research findings are based on case studies of just a few people. So for example, when I keyed into a research database, orthostatic tremor and physiotherapy, and this paper kept coming up again and again. Orthostatic tremor, 2 persons in a balance disorders practice. So this is what I'm having to work with when I saw Joy. What do I do? And there are no current clinical guidelines that exist for OT and physiotherapy. So unlike if you come to me and you have heart failure, type 2 diabetes, osteoarthritis, there's a mountain of evidence for physiotherapy and what best practices so that we can go to these guidelines and so that we can deliver the care to you in the most efficient way possible utilizing resources efficiently. But we don't have any. What does the little bit of research show? Well, it shows that there are positive benefits for balance, strength, and endurance training on length of time standing and postural sway. So that's something that Julian has more expertise in there. And physiotherapy is effective, and so we have to kind of bring in our neuro training here. So so with or without vision, meaning we train balance with eyes open and eyes closed. So if I stand here, I'll get out of the light there, with on one foot, yes, that's okay. I shut my eyes, it gets a lot harder. So they found that if they do training with people with OT, with their eyes closed, the effect is more pronounced, which you would expect it would be because it is for most people. And this is what you have to remember. Just because you have OT, all your other neurological systems and your cardiovascular system, etc., it's not that different. So when we're training, if you have trouble with balance, we do balance training. The same as if you had balance problems if you had a stroke or Parkinson's disease. Okay, so with that said, I approach treating OT with joy, combining the elements of the OT research, whatever little there is, with the systemic benefits of physical activity, of which there is a mountain of evidence. So we all have a cardiovascular system. We all need to be fit. We might all, some of you around here might have perfect blood pressure. Some of you might have really high blood pressure. So that's part of physiotherapy, is to bring in all of these systems. And that's part of what a good physio will do, is look at what's going on with you. What's your drug regimen? Oh, you've got high blood pressure. Okay, we need to address this. You've got depression. Well, exercise helps with depression. We know this. So when we're identifying problems, and this can be overwhelming, so you get people who will come to the practice and they'll say, I've got this wrong, I've got this wrong, I've got this wrong, and sometimes I have to literally stop them. So we have to identify the problems, and we need to prioritize them. So you have to, every physiotherapy problem is unique to you. So I tend to I learned this at school, and I find that this is a good system of helping to identify problems and prioritize them. And it's called the International Classification of Functioning, Disability, and Health. Just call it the ICF model. It's a lot easier. Okay, so going to the next slide. We're going to get back to that in just a second. But first, how to find a physio. There's a lot of physios out there, aren't there? So do what Joy did. When you make the appointment, call, ask them, is there a therapist there that has special knowledge or interest in neurological conditions? Maybe there is. Maybe there's someone that specializes in Parkinson's disease who has some good crossover with OT. Finding an OT specialist physio, the chances of that, very low. But finding someone that has experience who's interested in stroke patients, multiple sclerosis. It's important to find someone like that that has interest. So, and one of the reasons why I put up my hand was like, how many sprained ankles can I see? It's like another sprained ankle. Okay, well, I get a chance to learn something with Joy. So, and that's why what you're doing when you're going to see the physio is you're also assessing the therapist. They're assessing you, but you're also assessing them. Are they buying into, are they interested in my condition? Because if they're not, it's not going to work. The clinical relationship is not going to work. So never assume all physios are the same. And it was interesting, because I'm with Bupa, and nothing against them. But I see a physio for myself because she's really fantastic with knees, and I've got a problem knee here. And so I called my extras thing, and I said, I want to drop it, I'm changing, because the rebate is no good. And she's like, oh, just go to a Bupa preferred physio. I was like, yeah, but no, because I'll go there and they'll give me, I've been through like 4 physios already. It's like, no, I want to see this one. So just never assume all physios are the same. Okay, so you made your appointment, you found your physio they're very interested in neurological conditions. So at the first appointment, what might you need to do? Educate the therapist about your condition. They might never have heard of it. I'd never heard of it. So Melbourne University has an extremely good neurological program for physiotherapists, but they still had not mentioned this disorder. That's how rare it is. So, and knowing that you are your own best advocate. Only you can tell your story in the best way possible so that the physio doesn't have to just guess. And, so giving that information as much as you can, how it affects your life, be your own advocate. Okay, then we're going to get to, so we get through all of that. You need to state your goals for treatment. Let the therapist know the ways that OT impacts your life and what your prioritized goals are, which is why we'll get back to that ICF model. So if you have a lot of things going on, think about several of the most important things that are really hard for you to do that you want to achieve with physio. And that will make the therapist's life a little bit, not easier, but it will help to jumpstart that relationship. And so once we have all the treatment plan in place, one thing I cannot emphasize enough is to do your exercises. Oh my goodness. And this applies for everybody, whether you've got a sprained ankle or you've got OT. People rely on the treatment session to get better. It doesn't work. When we give you exercises, there's a reason why. So people come back and they're like, yeah, it feels the same. And I'm like, well, what did you do? I did. I'm like, be honest. And I'm always like, just be honest with me. If you didn't do them, just tell me. I didn't do them. Okay. But it still hurts. I don't know, does physio... And then they'll say things like, should I go see a chiropractor? No! So this whole thing about like having someone else, I'm just going to flop myself on the bed and you'll fix me. It doesn't work that way. All right? So next slide, please. Okay, so let's go back to this ICF model here about mapping your therapy goals. So this was adapted by the World Health Organization here. So up here we have the health condition, the structures of the body and the functions that are affected, the activities, which are at the center. There's no accident why they're at the center, because that's the center of your life, is what you do and what you want to do. Your participation, the environmental factors that affect all of this, and then the personal factors that affect this. So, for example, so if we put OT at the top, which actually we're going to do in the next slide, but don't go ahead just yet. So these things can be positive or negative. So, for example, environmental factors. What's an environmental factor? Well, it could be, so I see a walker down there. That's a facilitator. It allows you to come here today and participate in this activity. If you don't have that, then not having anything to help you navigate this room, that's a barrier. So environmental factors can be positive and negative. And so this is something to think about. Think about your goals. So I want to go, and you need to let the therapist know this too. Therapist says, I think hydrotherapy would be really good for you. You need to put up your hand and say, I don't have any way of getting there. I will have trouble getting in and out of the, like, how am I going to get in and out of my house? How am I going to get there? This is a barrier. So another environmental factor that could facilitate you getting to hydrotherapy is there's a service in your town that actually can take you there. So these are things for you to think about, and this is, again, being your own best advocate, taking ownership of what's happening. So, and we know there's a mountain of research that says that people with chronic conditions do better when they self-manage. So self-management strategies, okay? Take ownership of what's happening. People with type 2 diabetes, when they regulate their own blood sugar, when they're able to do the exercise, when they're able to self-manage, they feel better about themselves. So there's a big problem with OT and depression, as we've heard from some of the stories here. So knowing that people with chronic conditions feel better when they feel empowered, do it. So empower yourself. So this is why you need to not just rely on the therapist. So you need to rely on some of your own grit. And this is where we get into personal factors. So like, I'm like a really pessimistic person, right? I think the whole world is going to end in a disaster, and yet I act like, my actions, though, are of an optimist. It's very strange. So, but these can affect everything else here. Everything else here could be great, but the personal factor is the limiting factor. It's not going to work. It's going to be terrible. I'll get there and whatever, or you might have a belief from your upbringing about being out in public with an assistive device. I don't know. These are the things that you need to understand about yourself and think about. You know, am I embarrassed to have a wheelchair when I go to do this activity? So all these things, as you can see how they all interact with the central activity here. So going on to the next slide here, I've plugged in OT. So what's the big thing with OTs? With the problems with standing. So here we have standing at a social event. So the body function that is affected is the structure is the quadricep tremor, for example. So that's what's affected. So that, in turn, affects how long you can stand at the social event. So the social event is your part of your community involvement. So that's your participation. If you're not able to be involved in your community because you're not able to stand at the social event because of the tremor, you're going to decrease your community involvement. So, and then down here I put the tripod stool. So, okay, we've got all of this, but you've decided, you know what, I'm going to take a tripod stool with me. The event is 1 hour long. It involves standing. There's not many chairs. I'm going to take a tripod stool. Facilitating environmental factor. If there's no chairs and you don't take the tripod stool, that's a barrier. Okay, and then I put here pessimistic nature. So this can affect everything. Everything else can be kind of sorted out for you. And sometimes, and an environmental factor can be your personal relationships. So with your caregiver or your partner. They may say to you, you can do this, or let's do this, and you, no, I don't want to. And that could be the depression or anxiety or anything. So once again, that's something that can be a facilitator or a barrier. And that's where the personal factors come in. And so maybe here, when we look at these different components here, we think, well, what can I do to optimize all of this and integrate all of this? Maybe I need to go and see a psychologist for my pessimistic nature. Maybe this disorder has actually really turned me into, the lady mentioned over there, that she hadn't been smiling. Maybe that's the barrier in this ICF model that's preventing everything else that's happening here. So, and again, I'm going back to what the other lady said about exercise and diet. That's the whole integration of all your health team. So it can help with each element here. So you might have, orthotist who can help you with the tripod stool or adaptive devices or anything like that. Okay, does that make sense? Yes. Okay, have I explained it well? Yes. Okay, good. All right, next slide. Okay, so let's go through a little case study here. Feedback. Okay, so 60-year-old female presents with a 5-year history of OT, lower back pain, decreasing ability to stand, affecting ability to engage in social situations and everyday activities like supermarket shopping due to trouble standing in line, which is great. So getting very specific, something that we can measure as an outcome measure that's meaningful to the patient. So, I could do, I don't know if you've probably all done 5 times sit to stand, 10-meter walk test, how all of that, a lot of that you give it to people and they're like, okay. But if you can stand in line and pay for your groceries, that's a much more meaningful outcome measure for you. And so that's where I tend to go through the functional things, which we'll also get into. Okay, so she reports depression, anxiety, weight gain, and debilitating fatigue. On examination, she exhibits palpable antagonist-agonist tremor in the thigh, so that just means that both the quadriceps and the hamstrings are co-contracting, and I know in OT it can vary. She has multiple trigger points in the muscle from, the tremors, so her body's sore. Tender lumbar spine. She can stand for a maximum of about 45 seconds before needing to sit down. Community walking, so that's the participation, has been decreasing. And she's having trouble stepping up and down off the curb. Her balance is affected by the tremor. Doing a quick neuroscreen, so normal reflexes and sensation. She walks with a stick and uses a wheelchair for longer distances. Her goals are to increase standing time and community walking so she can attend various activities related to her hobbies, so meaningful to the patient. So this is why you need to go in there, maybe write yourself a little bit of a list. What's important to me? What do I want to get out of this therapy? Otherwise, for the therapist, it's going to be, okay, we'll give you some standardized tests and see how you do on those after you do the exercises, and it's just not going to be as meaningful. All right, so let's just go to the next slide. So the treatment plan that we came up with. Increase general fitness with gentle functional exercise. So, and actually, interestingly enough, when I was preparing for this talk, I went on to some support group websites, and quite a few people with OT mentioned that they'd gone to a personal trainer, and the personal trainer had kind of like put them through the mill and totally set them back on their heels. So, and that's striking the balance with the exercise of not too much, not too little. And that's where a physio has a role to play, whereas going to see a personal trainer or a Pilates teacher who doesn't have any kind of training in anatomy or neurology is not going to have the understanding of what's happening. So we created a structured home exercise program because she was starting from pretty much zero. We gradually increased time standing by increments of just a minute, as tolerated over time. So 45 seconds is debilitating. So we started doing this actually in the room, and I think, well, Joy, this is partly about you, but some of it's been, adapted. But it got to the point where you were standing for over 15 minutes at home. So I was like, you know what? We're using up all our treatment time with me with my iPhone, standing there timing her standing. And by the time we got to like 12 minutes, we only have a 30-minute session. I was like, you know what? We need to start doing this at home. I'm really happy that I'm standing here for so long and it's not 45 seconds anymore. But why don't you do this at home, look at the kitchen clock, and then come and tell me how long you stood for. And then we can focus the treatment session on something else. So we actually were getting, sorry? Eyes open? Yes, with eyes open. With eyes open, with eyes open. Yes, and unfortunately I moved away from Wargle before we could get to that more complex stuff. One of the papers, actually the paper that I mentioned in the beginning, mentioned a weight shift strategy to offload the limb to minimize the tremor. And I was like, you know what the hell, let's try it. Let's try it. So, she came in and she was standing, she's like, okay, and I felt the tremor. Yes, I feel the tremor. Yes, I feel the tremor. I was like, what if we start to offload that limb a little bit? And she's like, oh. And so I kept hands-on. Physiotherapists are hands-on. And I was like, the tremor does seem to decrease in its intensity when we employ this strategy. And that was really the key to get the standing time to increase, was with the weight shift strategy. So we tried it a couple of ways, didn't we? I think in the research it said to go from your toes to your heels, but really when you think about that, that's probably a surefire way to fall down. So we're like, you know what, let's forget that, let's adapt that, let's go side to side. Okay, so that was the strategy that worked. Are you still doing that?
Yes, even though the tremor is different with my comfort, I'm still trying to do that because the muscles are now kind of always tight.
Yeah.
So I figured by doing that it may release them somehow.
Yeah. So, and we did get good results with that. So, and that was good. And so going back to the anxiety and depression, that was really like, ooh, I could see a little spark in her eye. Things are happening here. So, even though I'd never even heard of OT, we were getting progress. We had developed a good clinical relationship. So I also told her to find a flat level path to practice overground walking, which is really important, especially out in Warrigal where everything's like this. So, with her partner, she was able to go, there's a straight, flat, concrete place to walk and practice there. So, and this goes back to environmental factors in the ICF model. If you live in an area where it's very hilly, well, get in the car and drive and find a nice flat place to walk, and you'll be less anxious, and you can practice there. So we would combine this with physiotherapist, manual therapist, very strong hands. I used manual therapy to treat her lower back pain and multiple trigger points. So she's very sore. Her body. So whose body's really sore from this disorder? Yeah, really sore. So hands-on therapy can make a really big difference here to help. So we, just for the average person, I work in Docklands, we have office workers, and they're all really tense and tight and sore from working at computers all day. So it happens to everyone. So we mix that in and with the exercise. And then she she mentioned that she liked doing the hydrotherapy, and I thought, okay, let's get her in. This is good because this has social support, gets you out there. You're not sitting at home by yourself feeling sorry for yourself. You go to hydrotherapy, some people have had strokes. It's also great for neurological conditions because you don't have to worry about keeping your balance. You can't fall in the water, and so maybe you can do a little bit more. Okay, and then we had regular discussion about fatigue, motivation, and medication. So it was really interesting because there is so much trial and error when it comes to medication for OT. So we would regularly discuss it, and she'd be like, I've changed this, I've upped this, I've down this. I'm really having a really tired week. And this is actually something that I want to mention too, is don't cancel your appointment just because you're having a really bad week, because your physio can really help you get out of that. So if you cancel, that's another, you can kind of either like, well, I'm feeling really terrible, I'm, not wanting to go out, and, the one person who's there advocating for you, you're also going to shut out as well. So keep that appointment. So sometimes we would just talk, wouldn't we? And you could see, like, just expressing your concerns, it's a little bit of a psychological support, it's a pep talk, so it's really important to get you back on track. Here's your exercises. Maybe we'll cut them in half this week, or we'll adapt them. But it's really important that you don't just cancel your appointments just because you don't feel like leaving the house. Okay, let's go on to the next one. So the treatment results. So progress was obviously gradual over time. We were able to increase the time in standing using the weight shift strategy, and we reached about 15 minutes without an assistive device. Now, I just want to mention too, safety in all physiotherapy. We did this standing in the corner. So if there's any risk of fall, you have this to hang on to, this to hang on to, and this to hang on to, okay? Or the kitchen bench. So you don't want to be standing out in the middle of the room doing this kind of stuff. And any good physio will teach you about the safety that's required for all activity. Overground walking time and speed increased. Participation in activities increased. So this is where the ICF model comes in. Meaningful, going to the beach, attending social groups, travel, hydrotherapy. I think it was your art group. You came one day and you were very excited. I was like, I was able to go to my art group and I was able to stand. It's meaningful goals achieved. And then just a general fitness increase. So, as I said before, you've all got cardiovascular systems. You've all got the normal health issues that everybody else has. So you have a human body. Strength, endurance, balance, mobility. And what I really noticed, so as a physio, what I do is when I walk down the hallway and I go to the waiting room, first thing I do is I look at how people get out of the chair. So when people come out of the chair and, if it's effortful, you can pretty much figure out what's going on before they even sit down. So what I did notice about Joy was that she was actually kind of getting up and out of the chair quicker. And I was like, we're getting somewhere here. So, but of course we had some weeks that were limited by periods of debilitating fatigue. And once again, then she would just come in and we'd just talk. But overall, there was an increase in the sense of self-efficacy. So this goes back to being your own best advocate and self-managing your condition. There's so much evidence that people with chronic illnesses, if they self-manage, they feel empowered, you will feel better. Okay? Exercise program. So this is a question that seems to be asked a lot on the message boards. What exercises should you do? Well, they should be functional. They should be related to your goals and problems. And as with all neuro, so I had a lady who had MS, and our goal was just to keep the level of function that she had. She wasn't expecting to run a marathon or do anything special. She just said, I just want to keep my ability to walk whatever the distance was. So a lot of the goal of neuro is that. We're hoping we can make improvement, but even if we just preserve what you've got, that is a big win for a lot of people, and especially for the caregivers too. Improving your cardiovascular fitness is going to help. So, and then that has the flow and effect of improving mood. But with OT, we have to be careful not to overdo it. So there's that fine line where I talked about the personal trainers pushing the people too hard, and then you're going to just not do any exercise at all. So it's that fine line that you have to walk. And the progress isn't always linear, so as we said, so you know that. All right, so let's go over and give you some examples of functional exercises. Well, we all need to get out of the chair. So sit to stand, stand to sit, not the same thing. So I used to work at the stroke unit at St. Vincent's Hospital here. So standing to sit was actually a big problem for a lot of people because it requires control. So we can all, force ourselves up. But the descent was the part that they had the problem with. So these are good functional exercise examples. Calf raises. Well, when you reach, a lot of the times you need to get up onto your toe. So calf raises. Squats. Well, that will help you with the sitting down. Stepping up and down on a step. Joy mentioned that getting up and down on the curb was becoming a problem, limiting participation and involvement in the community. So stepping up and down, training those muscles so that it's a little bit easier to get around. Balancing on one leg, so that's once again going with the reach. So sometimes if you've got a high shelf and you're reaching, you might need to come up on one foot to grab something. So it's always good to have balance and minimize the risk of falls. Pushing, you have to, push furniture, push things, push the door closed, anything. So wall push-ups is a good thing. So that's a functional. This is a functional movement. Pulling, pulling. So we put elastic bands around a door handle and pull. We need to pull doors closed, pull doors open. And then obviously reaching. So if you need to reach in your kitchen, you need to reach for food in the pantry. So these are examples of all exercises that could have they relate to real life. So if I give you a whole bunch of exercises like planks and all kinds of, they don't really relate to doing anything. And this is kind of like the basis of neurological rehabilitation, is that it must be functional and take you to your highest level of function. Okay, so let's go to the next one here. And this is when I interrupted before. So coordinate your care. So you cannot lay everything on just one person in your team. So your neurologist will take care of your medication, and they can track your function and things like that. And your physiotherapist can help you participate more in everyday life and increase all of that, your physical movement and mobility. So the good thing about Joy was she'd say we would communicate about what's happening with the neurologist, what's happening with the GP. What's happening with the pharmacist? You're going through you're guinea pigs in a lot of ways for a lot of this drug therapy. Social worker, for the carers, is this something that you need to coordinate into the care? Because it's very living with people with chronic conditions can be very tough and stressful. And obviously the GP. So having this circle here, we've all got a little piece of the puzzle. And that just coordinating all of those people helps to put it together. All right. Questions? Anyone have any kind of positive or negative experiences with physiotherapy? Yes, sir.
Thank you. I can't remember your name. Adam.
Adam,
we live in Albury Wodonga,
Mm-hmm.
so therefore access to you perhaps at Docklands is no good. We understand a bit more about how we access or how to choose a physio. How often should we see a physio?
Okay, that's a very good question. So it depends on. So everyone's at a different stage. I would say in the beginning, I think I usually see people weekly for OT because it's not something that like a stiff neck. Okay, I need to see you like every couple of days. In the very beginning. So this is a long-term project. So I think that it was like once a week for several weeks, and then it became a monthly thing, because that was really important, because that you can check in and see whether it's all kind of just starting to unravel and reset. So I would say weekly until you feel like, okay, yes, I've got the handle on the, empowered to do your own exercises. and then going to the physio once a month to make sure that you're on track.
Right.
Yep.
Thanks, Adam.
No worries.
I've noticed lately that if I go to a swimming pool, and when I get out, I feel really like I've got no strength in my legs whatsoever. I feel like really heavy.
Yeah, now that's a common feeling, and it's not just with OT. So hydrotherapy is a bit of a fake out because you're working harder in the water than you realize because you're not having to balance yourself. So land exercises will kind of give you that instant feedback of fatigue. It's also the hydrotherapy pools are heated to a certain temperature. So, and that can also make you feel tired too, but that heaviness is quite a common report from people who do hydrotherapy. So, does it pass?
This is not hydrotherapy, this is just in a pool swimming.
Oh, in any pool. In any pool. Okay, so yeah. So it's because in the water it is. So if you think about walking in water, it's a lot more difficult. So you've done a lot more work. But it doesn't sometimes feel like that when you're actually in the water. So I will at the hydrotherapy pool in Warragul, people will do their class and they'll get out. You can see them getting out of the water, and they're just, oh my goodness. So and that's once again straddling that line of like too little or too much. So, but that is a common effective hydrotherapy or pool-based exercise that you need to consider.
I'm saying, I come out of the pool, we've got to be in our life, put a chair by the stairs when I come out of the pool. When I come out, I have a chair by the stairs. When I come out of the pool,
Yeah.
I sit down on that chair
Yeah.
until my body readjusts to the different sort of gravity and that kind of thing. And then I can stand up and walk to the changing chair.
Yeah.
If I can't, otherwise I'm stuck as I come out of the pool and
Yeah.
I cannot move.
Yeah.
I have to still hold on.
Yeah.
But the chair is a sort of interim stage that works, and might work for others.
Yeah, that's a good tip. So whatever it takes. But one of the things is make sure that when you're doing hydrotherapy, and if you're not doing it with a physiotherapist and just doing it with a general teacher, that they know that what your condition is and that you do have a fatigue limit. So you'll see the exact same thing with multiple sclerosis when they get out of the pool. It's just like, oh, it was great. They get out of the pool, and it's just the exhaustion. So you're working harder than you think a lot of the time.
I also have a question, so while I have the mic.
Yeah, no worries.
captured
Yeah,
here.
of course.
When we go to the neurologists, they use a device to measure the tremors in our legs, and we can, if they've got the amplifier on it, you can hear the helicopter effect.
Yep.
And there's other ones you can have on your phone. Do you use that sort of diagnostic tool when you're working with your patients?
Well,
can you sort of test whether the tremors are increasing or decreasing?
We don't really have those. Like I have a stethoscope, so you can hear it. But as far as being able to like pinpoint the difference in the hertz, I'm not able. That's his wheelhouse there. but it tends to be with the physio. It tends to be self-report with the tremor. But we don't have the resources or the tools in the average physio clinic. So maybe if you go to St. Vincent's Hospital and you go to an outpatient physiotherapy there, they may have a resource there where they actually have those kind of tools, but they tend to be extremely expensive. And for private practice, we just don't have the resources for that.
I agree. Just use clinical. So I use eyes closed, feet together.
Yeah.
And if you can, and then from there, so
eyes closed, feet together. Okay, there we go.
And I agree. You just get bored if you're going. You're doing really well. It's gone 2 minutes.
Yeah, yeah.
And if the eyes were closed, you could just go for a coffee.
Yeah.
I'm standing.
That's true. That's true.
Adam, I'd just like to reinforce everything that you've said. I go to an exercise physiologist, and it is really important, the relationship. He makes me feel guilty if I don't, and I don't do the exercise, and I just go in and say, would you like the truth?
Yeah. And that's
or would you like me to pretend? But he does make me accountable. That's what I find, and that is so important because I do feel guilty, and I will certainly, I do them off and on, but every time I think about it, then I get the exercises going.
Yeah, and that's one of the other traps that a lot of physios will fall into is giving you too much. They'll give you too many exercises. So as a rule of thumb, I mean, people come to me, and if I give them any home exercise, it's 2 or 3 at the most. Because they'll look at it and be like 4 or 5 exercises, I'm not going to do any of them. But if you give them 1 or 2, they're more likely to do it. So even though the evidence says give them this, and this,
Adam,
reality. Yep.
Sorry. Adam, I've got a Pilates machine
Yes.
at home because there's no way I could stand there and do it. I'd fall on the floor or whatever.
Mm-hmm.
So I'll be honest, I haven't been on it lately, but I bought it because it will strengthen my core, my legs, my arms, everything. I've been very naughty, but I promise I will get on it when I get home.
Hopefully you've been inspired.
So what do you think of Pilates machines?
I'm a clinical Pilates physiotherapist.
Oh, see, mine is too.
So, yeah.
So
I have a lot of experience in treating people of all abilities and disabilities with Pilates. And it's a tool like any other, and it's a form of exercise like any other. What I do find that's good with people who have limited mobility is that there's a lot of holding on, support, that does I can prescribe exercises where the machine does like 50% of the balancing for you. So it's a good way to transition to harder things. So I find it's a very versatile tool for that. But it's just, like anything, it's another form of exercise. Yeah.
Tell us about dry needling.
Yes, I do dry needling too. Dry needling is fantastic dry needling is good if you don't have any of the contraindications. So if you have bleeding disorders, if you're on blood thinners, warfarin, or things like that, so you would have to go through the therapist, and there's kind of a list of things that are what we call contraindications, or we shouldn't do it because you're putting. I mean, it is very effective for trigger points, and people with OT have a lot of trigger points and very sore. So with Joy, I tended to just use my thumbs. So, which has kind of the same result. But dry needling, if you're cleared to do it based on the rest of anything else, the issues that you have or don't have, then I think it's fantastic for therapy. Yeah. It's like acupuncture, but we don't really believe in all that meridian stuff. We base it on pathology. So so if someone comes and says, I've got spasming in my glutes, and it's like I can there's a palpable trigger point in there, we'll stick the needle in there, and we treat it that way. So we're not saying I'm treating your liver or your spleen or things like that. So we treat it more based on what the presenting problem is. Yep.
I live in Aireys Inlet on the Great Ocean Road, and I've
Yep.
had a lot of trouble trying to find a physio that
Yeah.
has any interest.
Yeah.
I'd love to come up and see you, but and I would on the train, it wouldn't be a problem. But do you take health care plans?
We do. Yes.
You do?
Yeah.
Because
Yeah.
the cost of this, I don't know what everybody else finds.
Yeah.
I go to clinical Pilates.
Environmental barrier. Yeah.
Twice a week, and it costs me a fortune, but it's
Yeah.
worth every cent.
Yeah.
But that's why if we can use a care plan with someone
Yeah.
like yourself for a bit, and then, pay, because I don't have private health insurance.
Yeah, so care plans, what you can do with care plans, and so I have some very, very canny patients who've got chronic conditions, and I've even had ones with, they've made up Excel spreadsheets, and they're like, if I use I'll get 5 of my care plan visits. I'll come in January, I'll use that one, I'm going to pay in February, and then March, and then da-da-da, and then I've got my private health insurance, which is the lowest level, whatever, and they'll manage to get a whole year of therapy for the least amount of money possible. So sometimes you just have to be a bit creative about how you fund it. The alternative is really buy into what your therapist, when you find that you've got a good care plan, treatment plan, self-manage. So you don't have to go to the physio as often. So that you're just checking in maybe once every 2 months, and that way it's a worthwhile investment. So every 2 months, it's a worthwhile investment to go, but take on board more of the responsibility to do it yourself. Yeah, with the guidance of the physio. Yes.
Can you speak to us more about I was asking you if you could speak to us about the deconditioning of muscles and if that can be reversed or at least stay at a...
Yeah, so it is, and this is what I was talking about before with the personal trainers that get OT patients. And they'll just put, they'll do the same progressive overload, they call it, so heavier and heavier weight. And that's, obviously not something that is tolerated by a lot of people. But muscle is muscle. Your body, yes, you have OT, but you still have a normal human body. So cardiovascular fitness, going to the gym, doing some form of resistance training, which I said before, the evidence said it's effective. So not doing anything, yes, deconditioning is a problem for everyone. So when I was at St. Vincent's Hospital, one of the big studies they were doing there is called pre-frailty. And that was about catching people before they get so frail that they end up in the hospital and it's all too late because they have no reserve. So you have to think about that. You need to keep yourself at the maximum level of function within the limits of what you can tolerate. So absolutely, you can improve your fitness by doing more exercise. You can improve your muscle tone in more of the unaffected muscles. You might have more trouble with the legs or whatever body part is affected, but yeah. So, but you can always everyone can improve their fitness. Yeah. Anyone else?
You probably hear me, Ken, but this is related to my original question about how often to see a physio. So now it's not about you, Adam. It's about Julian. Okay. I'm just very, very wise. I was just wondering. I don't know when Helene and I went back to see the neurologist last. So how often should you go to see the neurologist?
He did say 6 months for his patients. He mentioned 6 months earlier. I don't know whether that was a rule of thumb or...
No, that's okay. That's enough. Just because sometimes you feel like it's a once, it's OT, and then I'd have to go back there. But what we're hearing is there's a team effort here between the neurologist, the physios, the GP, everybody else as well. So should we be going back to see our neurologist more regularly? That was the point of my question.
The man who's got the answer stepped out for a moment.
So just to, does anyone else have any questions? Okay, so actually I did have a slide up here that showed how you can contact me. So just want to bring that final slide up again. There we go, that one. So here's the email. So I check this email every day. There's the website for the clinic and the location there. So if you have any questions about treatment, Joy's got my business cards. So yeah, if you send an email to info@docklandshealth.com.au, I will definitely receive the message and I will definitely reply to you.
So Julian's just stepped back in, so I'll bounce the question to him that was asked from the floor. Julian?
Yeah, it's great.
Hello?
Sorry. We're having our own conference here.
I really like the side-to-side thing.
You had a question from the floor. Somebody asked...
How often? Well, if you're going to try a new drug, obviously more often, because you need to be monitored. Otherwise, if people are stable, 6 months is fine. Arguably, mainly because that's when the repeats run out. And like I said, when I answer questions like how slow is the progression, that's how I can tell. Because if you don't see them, if you see people every 2 years, and you go, wow, what happened? That happens like with other diseases where there's non-linear progression like Parkinson's. So for the most part, people are stable. Something happens, operation, whatever. Or there's actually, if I can, I always try and work out if there's a reason. A reversibility, deconditioning, and then send them to Adam to be flogged. Because you can see there's a great picture of a 70-year-old triathlon. He's got the quads of a 40-year-old and a 70-year-old average sedentary man, and all the muscles just tend to fat. And you can reverse that to an extent. Does that answer the question?
Thank you.
So that brings to the close of our morning session. Would you please join me thanking our speakers today, both Adam and Julian?
Thank you.
Very
Thank
much.
you. Thanks, Ken.